Next, I'd like to introduce our third speaker, Dr. Joseph Matsumoto, who went to Mayo Medical School in Rochester, Minnesota, and completed his residency at Mayo Graduate School in Rochester. He completed his fellowship in neurological disorders and stroke at the National Institute of Health in Bethesda, Maryland. He specializes in movement disorders, DBS, and clinical neuropsychology. He will be presenting about new therapies, research, and care options for Parkinson's. Let's welcome Dr. Matsumoto.
Thank you, Erin, and it's just been a wonderful, wonderful morning and afternoon, and I'd like to take a chance to applaud Erin and the Parkinson's Foundations for putting this together. Thank you so much, Erin. So my charge today is to talk to you about research in Parkinson's and how it comes to you in your everyday care. I don't have anything to disclose. Parkinson's Foundation has been so dedicated to research. We just heard that now it's over $10 million a year that they devote to very basic research in Parkinson's disease, and $330 million over the life of the organization, and that's making a difference. And we'll talk about where it's impacting you. So, waiting for the cure. That's tough to be a consumer of Parkinson's research. You look on the internet and you see things, or this happens to me every day. Someone says, boy, my sister-in-law saw this article. There's a cure for Parkinson's disease. Tell me about it. So I'll take out the sheet and I'll read it, and you'll see me look at it, and then I get more interested. I'm going through things, and I'll look at you and I'll say, I didn't even know Meghan Markle was pregnant. And then you say, hey, stay on task. What about the cure for Parkinson's disease? And I'll say, oh, that's bunk. Don't worry about it. So reading, consuming research about Parkinson's disease is a little bit like being a Vikings fan. You read it and you say, boy, this is the winner. We're going to the Super Bowl this year. There's gonna be a cure. And then you come and see me and I deflate the balloon and you feel like this guy, right? Thank God for our dogs, huh? So you hear things and you get discouraged. But now there's much more reason to be encouraged. So I want to give you a little guideline about how to think about research in Parkinson's disease. This is how research progresses. The drug companies call us the pipeline, okay? So way on the left-hand side, you can see studies that either are in populations, people who take anti-inflammatories don't get Parkinson's. You read things like, oh, they cured Parkinson's cells, or in mice, they've given something and every one of them got better. That's called preclinical research. And the joke in research is that there isn't a disease that hasn't been cured in the mouse yet. So you read that, you get encouraged, but don't take it to the bank. Don't get too excited. If preclinical research looks exciting, then it will move to what's called phase 0 or phase 1 studies. Those are actually done in people without Parkinson's disease. It's just looking to see if a healthy person can take a medication or get a therapy and tolerate it. That's exciting, but the next thing is if it moves to phase 2. That's when you should start to get excited, because that's in humans, and they're looking to see if it has some efficacy for your disease. And then if it gets to phase 3, they're looking to see if it's better than what's currently available. Is it better than Cinnamon? If it's DBS, is it better than the way we used to do DBS? Is Jing's way of doing DBS better? And for the cure for Parkinson's, slowing down the disease, stopping the disease, there isn't much that it has to prove that it's better than, because we don't have much at this time in that area. Ooh, something happened there. Okay, so research in Parkinson's disease happens for different stages of the disease. And I like to think about Parkinson's, and many of you think about it by the questions you've asked, as the stages of Parkinson's disease. So the first stage is the stage that someone was alluding to. We call it the prodromal stage, or the stage before you can really tell you have Parkinson's disease. What's it like in that stage? You lose your sense of smell, as Dr. Nance said. You act out your dreams at night. That's called REM behavior disorder. Maybe you have constipation. That's the only sign. Sort of the things that you don't associate with Parkinson's disease until after diagnosis. The second stage is what we call the honeymoon period. And looking around the room, I think a lot of you are in the honeymoon period. That's where you take your medicine, you feel good, everything's fine, you get your medicine refilled, you go into your doctor, they say you're doing great, refill your medicine, everything is good. The next stage is called the fluctuating stage. That's where you take your medicine and you say, yeah, it's good, but say, Dr. Nance, 2 hours after that, I start to feel bad again. I feel like I need it again. That's fluctuation. And a lot of research studies are aimed at that stage. All of these stages progress at different rates, and sometimes it can be over decades. It's slow, but the rate is different for everyone, all right? And then there's a final stage that not everybody gets to, again alluded to by some people, that we call the non-motor or complicated stage. Memory problems, hallucination, autonomic problems like bladder problems or fainting, freezing and falling. That's the stage we don't want to get to. That's the stage we don't have a lot of medications for. So today we're going to talk about 4 things, 4 different words, where research is making a difference. We're first going to talk about new systems of drug delivery. These have been done mainly for people in the fluctuating stage. My medicine works, it goes away. Then we'll talk about deep brain stimulation, just sort of review some of the things that we've heard about earlier. Next, I want to take a little bit of time to talk about alpha-synuclein, the chemical that's involved in most patients who do not have genetic Parkinson's disease, we believe. This is the excitement. This is where there are new agents coming out of phase 1, going to phase 2, that look like they may slow the progression of the disease. And third, I want to introduce you to a word that's called palliative care. That has some bad connotations, but there's a lot of research being done. I want to orient that word for you, okay? So, the fluctuating stage of Parkinson's disease, what happens? In this diagram, you go on and you come off. It's like living on a roller coaster for some of you. The medicine works, you feel good, then it goes down before your next dose. You got to get one and wait for it to kick in again. And it makes life unpredictable. Some people will say to us, I don't like to go out because I don't know if I'm going to be on or off when I go out. It's too unpredictable. When you're off, it may be severe to the point where you can't move. You may get stuck somewhere. When you're on, you feel good, but you also may have these extra movements, dyskinesia, which are embarrassing to you if you go out with friends. So what do we do in Parkinson's work? This is what Dr. Nance and I do a lot of. We adjust your drug doses. We say, oh, take it a little earlier in the day. Oh, take an extra dose, and we try to minimize the on and off, and we can be somewhat successful, but really pharma has come up with a number of better ways to do that, or new ideas of ways to eliminate the ons and the offs, or the bad ons and offs. So, rescue therapy, what do we mean by that? You never feel so bad that you feel like you need rescue, but the term means you get in a bad off in a situation where it puts you in a bad situation. I'm on an airplane, everybody's getting off, I know I got to get off, but I'm off now, I can't get up, what am I going to do? Okay? You're in a line, people are moving, I can't move now, what am I going to do? So people have come up with ideas of doing something suddenly. You know that when you take your levodopa orally, it usually kicks in about 25 minutes or something like that. You can't wait that long. So one thought is the apokine injections, which have been available for a long time. You have an injectable medicine that's called apomorphine. You give yourself a shot, and then within minutes, usually less than 10 minutes, you get an on state. That's available, has been available for a long time. There's a new therapy that is inhaled. Kind of looks like this thing. I shoot a little levodopa in, and I kick in about 15 minutes. That's available now. That's gone through phase 3. It's gone through the FDA. It is now marketed. Another thing is called an apomorphine gel strip. It's going to look like one of those breath things that you get. You put it under your tongue, it melts, kicks you in within about 10 minutes. That is at the FDA. It's required to give them a little bit more information before that's approved. So those things are available if you have these severe, inconvenient off periods. More commonly, what you have is the roller coaster. You're going up and down, not all of you, but the ones in the fluctuating stages. You're going up and down, makes life unpredictable. You say, why can't I just be on all the time? Well, when I was at NIH, I always remember that a doctor there named Dr. Chase would bring patients with this fluctuation in. He put in an intravenous line, and he had the ability, which we don't have otherwise, to inject levodopa and keep things constant. The people were absolutely normal all the time. So the point is, if we could keep your levodopa level absolutely stable at the right level in your bloodstream, you would not fluctuate. So how do we do that on a practical basis? Well, one way is to make long-acting medicine. And some of you may have heard of Rytary. That's like the old contact capsule. It's drug that's released in time capsules. It's more stable. Not perfect, but pretty good. Another is long-acting Recrip or pramipexole. There's a long-acting amantadine if you want to keep your fluctuations down. And there's also this pump that's available. That's called Duopa. Requires having a pump in your stomach, but it can pump levodopa in and keep your level just about constant. There are new things. Someone asked, is there a new way to do this besides orally? And yes, there is. There are two companies that are testing, these are in stage 3 or phase 3, intradermal levodopa infusions. So you put a little thing that they use for diabetes now onto your skin. It pumps levodopa in through a pump, and it keeps your levels pretty constant. Unfortunately, the first use of this has developed some nodules that have been troublesome, but they're still working on that. Another pill that has been through FDA is called the accordion pill, which is a little like the Rytary, but in this case they have things that sit in your stomach that are folded and release the medicine slowly, again aiming to give you constant drug therapy. So all of these things are available or will be available, so there's been advances in this drug delivery. Let's talk about deep brain stimulation, which Jing had talked about. We're very proud at the University of Minnesota to be really one of 2 places in the US where the federal government has charged us with making better deep brain stimulation. And I'll tell you, it's so exciting to be around people like Jing and other brilliant people who are trying to think of ways to do that. So deep brain, this is our group. Jing, you're on the line below that. I couldn't get the slide size right. But we have a lot of people working. This is Dr. Harrell. One of the things about DBS is it's like real estate, location, location, location. You're off by a millimeter, the effects are not so good, so we have to find a way to get better at putting things right where we want it. So if you think about it, it's like having a cantaloupe and somebody says, I want you to take this probe and hit the seed in the middle of the cantaloupe. Well, it's difficult to do, so you have to have computer programs, good imaging to make the right path to the target. And what he has done is he's gone from 1.5 to 7 Tesla. Tesla is a unit of strength of the MRI. And with that, he's actually able, on the right there, to make models of the places that they're trying to get to so that they can target the exact spot where they want that lead to go to. There is a model there. The next thing that has happened is that people have made leads that can segment or point the current off in a certain direction so you only hit the spot that you want. This is from Dr. Tuitt. He made that slide. So he can just maybe take it off to that side, improve things. And the other thing that is coming up is there's going to be the ability for these leads to sense. What does that mean? Right now, the leads just fire. We don't know what the brain is saying, like Jing said, but they're making stimulators that will sense the brain's activity. And if you look at those, I'm not very good at using this pointer, but might be because I have it backwards. No, even that didn't help. Anyway, you see those graphs there with all that orange and red and yellow? So all this, that red stuff are nerve cell firing. You can sense that through the DBS lead. Right now, we can't make any sense out of it. It's like getting an owner's manual written in about 20 different languages. We don't know what it's saying. But brilliant people like Jane and other people in the Udall Center are trying to decode that. What's the importance of that? For example, if you're walking and you freeze. Some of you may not have that, but some people will walk and they can't get the next step going. What if we knew the pathway, and this is from a 7T MRI, that started walking, and your brain sensed that you wanted to start walking, and right at that moment it fired and got you going. That's what they're trying to do at the university. Find things that sense what you want to do and fire in the spot where you need it. So that's the excitement of DBS. That's what we hope for. DBS is very safe now. We can make it better, and we are making it better. So now we're going to talk about alpha-synuclein. I know when I was in medical school, when people started pulling up biochemical names, my head dropped. I got sleepy. And you've just eaten lunch, so this could be worse. But I want you to remember this chemical, and bear with me for a little bit as we go through some slides that are kind of tough, because you're going to hear more and more about alpha-synuclein. What is it? Well, we know, some of you talked about Lewy body disease. We know from a long time ago that if you look at Parkinson's patients in certain cells, I'm doing that pretty well without tremor. There's little inclusions that are called Lewy bodies. This is what it looks like in a microscopic section. And for a long time when I was in medical school, people were intrigued by it. What are Lewy bodies? I don't know what they are. And then as Dr. Nance said, we learned when you dissected these that that Lewy body is full of alpha-synuclein. And then we found that people with genetic abnormalities of alpha-synuclein develop Parkinson's disease. So that was the first clue that this is going to be very important. Okay, so those little molecules are supposed to be alpha-synuclein, and they're in your nerve cells or in a lot of different cells. And then if something changes, they start to clump together. See them? And when they clump together, 4 of them, they're called an oligomer. Oligo means few. And if oligomers clump together, they become Lewy bodies. Okay? So you have free alpha-synuclein. Just a little change in that orange area will cause them to get sticky. If they get sticky, they form oligomers, and if the oligomers stick together, they become Lewy bodies. Actually, the dangerous part of that is the oligomer, we're learning. Something about the oligomer is toxic to the cell. And not over an hour, not over a day, but over years, if this builds up, it can injure and eventually make the cell die. That's what's going on in Parkinson's disease. So what is the other bad thing about oligomers? Here's a bunch of oligomers in one cell, is that they escape the one cell, they'll move to the other, and they'll polymerize, and they'll cause the process to spread. So pathologists know in Parkinson's disease that it may start in little small areas, but that over decades, it starts to spread. Okay? And then when it spreads up into this part of the brain, that's when you get hallucination or memory problems. So that's what we want to do, is stop that spread. And that's what people are working on. Here's a slide from Dr. Tuitt, and this indicates the newest thought in alpha-synuclein, that maybe it starts in your bowel. We know people with severe constipation are 3 times more likely to develop Parkinson's disease, so something's going on in the bowel. And people think that maybe there's something in the microbiome, inflammation or something that changes a little bit of alpha-synuclein. We know it's in the bowel, and then that gets transmitted up a nerve called the vagus nerve and goes into the brain, and then that starts that process I talked about. Another place maybe it's starting is up here where the smell comes in from your nose, the olfactory epithelium. Maybe that's where it starts. That's the current thinking about Parkinson's outside of the genetic forms that Dr. Nance talked about. So how would we stop it? We know that it's made, as Dr. Nance said, from the nucleus, comes out, starts to aggregate, gets sent out into another cell. How would we stop that process? People are developing a huge amount of resources and attention to that in industry, mainly pharma. They're thinking, well, maybe I could get an antibody. Here's some antibodies that would stop that. Maybe I could stop the transport channels here. Maybe I could get a molecule that would stop the stickiness of the alpha-synuclein. And then maybe I could get something that would turn off the production of alpha-synuclein. The good news for you is that some of these are going into phase 2 trials now. So we know along that pipeline they're getting there. Other ones are starting phase 1, but they're out of animal studies except for the stopping the RNA here. But in fact, now that you are expert geneticists after Dr. Nance's talk, you know, I've forgotten how to use this already. Oh gosh, I'm going back. So you know that there's what's called the central dogma. That is, you have DNA, as one of our biochemists out in the audience said, you get RNA. RNA goes on to make proteins. If it's a mutant protein or a bad protein, it becomes an oligomer, it becomes a Lewy body. Oligomers spread and are bad, okay? So one of the most promising therapies, even though it's not been proven in animals, is the idea that you can put in a piece of RNA that zips exactly to that RNA and blocks production of alpha-synuclein. We know in experimental animals, if you can reduce the production of alpha-synuclein by about 30%, that you can cure experimental Parkinson's disease. But I told you we do that in about everything. So, but that's exciting. So the idea of doing that is exciting, and the words that you should remember is small molecule therapy. That's the key word, and that's what people are looking for. Now, why am I excited about that? Dr. Nance is excited about that because, number one, it has cured other diseases that we thought were incurable. One is called amyloid polyneuropathy, another one is called juvenile spinal muscular atrophy. Things that we never thought would be cured, small molecule therapy has improved or cured or slowed the progression. The next reason is that, as Dr. Nance indicated, a study just came out that showed in another disease that affects the brain called Huntington's disease. In phase 1 trial, it was looking like it was tolerated and it was effective in reducing the level of a bad protein. I think this is going to be exciting. I hope it moves out quickly. It's in preclinical study now. I hope it goes to phase 1 and it moves through the pipeline quickly. I think that has real excitement for all of us in Parkinson's disease care. It may have excitement for you. I hope so. I hope so. So, final words we're going to talk about is palliative care. When we think about palliative care, we usually think about end-of-life care. A lady came to our institution once and said, I'm going to talk about palliative care in Parkinson's, and I said, get out of here. I don't want you talking to my patients about, end-of-life care. And she said, no, it's something different than that. So palliative care is not only end-of-life care. And I'm going to tell you what it is because I think it's remarkable that here in the state of Minnesota, people had so much foresight. Let's take a second to read this. This is the definition of palliative care. Palliative care aims to reduce suffering and improve quality of life of patients and their caregivers using resources beyond the physician-patient relationship by addressing emotional, educational, spiritual, financial, social, I should add physical therapy, occupational therapy, speech therapy needs, beyond the traditional physician-patient visit. I'm sitting in a lot of physician-patient visits, and I know when patients leave, I feel like I was inadequate. I haven't addressed what the patient or the caregiver was really asking me. I don't have time to do it, honestly. I can't tell them about exercises. I can't advise them about what to do with their finances. So there's a lot that concerns you that in the 20-minute visit when you come back, I can't address. So who had the idea that maybe we should do more? Well, there was a man named Paul Silverstein, who many of you may know, who started the Methodist Parkinson Center, became the Struthers Parkinson Center, get this, in 1978. So way back then, he had the vision to see that it wasn't enough and we needed something more. But he didn't call it palliative care. Well, academic medicine has been late to the party, and now academicians are getting interested in it. It's like with my wife when I say, honey, you know what you said a little while ago was right. And she says to me, I'm always right. It just amazes me how rarely you listen to me. So, and she's right about that. But, so now everybody is looking at palliative care with this new vision. It's not end-of-life care. It's not saying, let's make out your will. It's saying, let's look at your life. Let's see how we can make it better. And we already learned a little bit in these studies. Number one, the patient with Parkinson's disease. This amazed me. The predominant feeling that patients with Parkinson's disease have from the moment they're diagnosed is a sense of grief and a sense of suffering, even when they aren't severely affected. Grief for the health and the life they think they've lost, suffering from the burden of thinking, what's going to happen to me? And what do patients at that stage want? They want to know, what do I have to look forward to? Don't tell me exactly, I know you can't tell me that, but give me the best and the worst case scenario. Tell me, should I keep working? Tell me what I can do to help myself outside of medicine. And as far as these medicines go, tell me what I can expect from it, tell me what I ought to watch out for it. All of these things need to be addressed from the first visit, periodically thereafter. So that's palliative care for the patient. We're trying to learn how to use it. I mean, people like the Parkinson's Foundation, the Struthers are way ahead of us. They'll probably lead these initiatives, but these will make a difference in your everyday life. What about the caregivers? And I talk to caregivers every day. And I think I hear what you're saying, the change in your life. Social relationships start to get trimmed down. If you get out by yourself, you think, if the phone rings, oh my God, what happened? I better go home. You're living that all the time. And then people want to say, oh, you're a hero, you're a martyr. You don't want to hear that. You don't look at it as a sacrifice, because you look at it as something that flows naturally from the love and respect you have for your loved one. When they look at it with palliative care, the academicians doing studies, the major question a caregiver has is, how do I do a good job? What do I need to know to do a good job? That's the major thing you want to know. When we look at caregivers and patients together, we're learning things from palliative care research. We're learning that the first time a patient has a memory problem, patient's quality of life goes down, caregiver stress goes up. First time a patient has an autonomic problem, patient's quality of life goes down, caregiver stress goes up. First time a patient falls, patient's quality of life goes down, patient stress goes up. Maybe that all makes sense. We didn't realize how severe that was. What do we do then? That's what we don't know, and that's what new studies will look at. What's the right way to approach it? What's the right way to help you when that happens? We know that caregivers who give full-time care have about a 40% chance of getting an illness because they're giving full-time care, and we know that that risk drops greatly if the caregiver gets a couple days off of respite. So there's a lot that we're learning, a lot of ways that we can help you until the cure comes. Well, I've been rooting for the Minnesota Vikings for, I think, 60 years now. And I've been doing Parkinson's care for 30 years. And I'd say if I have to guess, a medicine that's going to help Parkinson's disease, slow its progress, maybe we call that a cure, slow it down, I think that's going to come before we win a Super Bowl, frankly. So you can put your money on it. But thank you very much for your attention. And thank you for coming.
Thank you. Let's take some questions for Dr. Joseph Matsumoto. Grace, can you go down there?
This year for the Vikings.
Okay. There's a true believer there.
Thank you for your presentation. My question's around, we've heard a lot of things about devices and pharmaceuticals. Where do you think the biggest bang for the buck is? Where do we put the effort in research? Is it 50-50 or is it 60-40? What's the split on current research going on for Parkinson's disease with pharmaceuticals and devices?
That's a good question. I got to think about that for a second. Well, I think what everybody wants is the drug that slows the progression of the disease. I think that's where a lot of academic research, pharma attention is going. Is that going to make a difference soon? I don't know, but is it going to make a bigger difference in the long run? I think yes. In terms of what's going to make a difference in the short run in your symptoms, that sort of depends on what symptoms there are. In terms of fluctuation, both DBS and these newer drug delivery things, I think are going to make are making a big difference. So it's short-term, long-term sort of decision about if you had to put your money on one of them, where would you put it?
More questions? Oh, I see one back here.
I have a question.
Okay.
I'm over here.
Oh, okay, up there, hi.
What is the correlation between exercise and Parkinson's? What does the exercise do to the genome? They both help each other, but what's the connection between exercise?
Yeah, that's a very good question, and you could give a whole talk on that. There are at least 10 studies that show that exercise benefits Parkinson's, even in the absence of any drug change. When you measure the Parkinson's symptoms after a period of exercise, those reduce. A couple questions, though. One question is how much exercise? And in the studies that show benefit, it's a significant amount of exercise. So it's getting on a treadmill, getting on an exercise bike, getting your heart rate up. But you don't want to discourage people to say, well, if you can't do that level, you shouldn't do it. We think it all has benefit. The second question is this a lasting effect? So again, you heard about, do we slow the progression? Is it disease modifying? We don't know at this point if exercise over the long term affects the progression of disease. We think it does, but those studies are not available. But in terms of, symptoms, making yourself better, there's no question that exercise is effective. Does that answer your question, or?
Another question, I hate to exercise. I found that going to, I'm at a community center and doing their Silver Sneakers program, that seems to fill the bill pretty well. Do you agree with that, or are you familiar with?
Oh, absolutely, yeah. So the exercise has to be aerobic, okay? Well, there's two types of exercise that seem to help. Let's go back to preclinical studies. In rats, when they exercise them, they increase the level of growth factors, in particular a growth factor called BDNF. And we think that BDNF is what mediates the survival of cells. The increase is marked, but there are two types of exercise that do it. One is called interval training. I tried to do that, and I only tried it once. That's where you go really hard for like about, I don't know how many seconds, and then you get a minute off, and then you go again, and by about the third minute, you say, forget it, I'm not going again, That increases it the most. So if you can do that, that's the best form of exercise. The other one is prolonged exercise, and that's getting your heart rate just slightly accelerated for 30 minutes. That seems to be the duration. And at about 30 minutes, the BDNF gets released. So if your Silver Sneakers gives you that sort of exercise, that's good. Aerobic for about 30 minutes duration.
Thank you.
Yeah,
Oh, I'm sorry. I shouldn't be calling on anybody.
I'm wondering two things. Is there any data on whether blood clots are a complication of advanced Parkinson's? And two, does the university have any plans to provide training for programmers for these advanced DBS devices? Because it's great if we can create them, but they're useless if we don't train the programmers how to handle them. And lastly, I just want to congratulate the university on being designated a Udall Center, because that's a huge deal. And I think we should do more to recognize that.
Well, Thank you. I'll accept the congratulations, so I had nothing to do with it. But, yeah, we're very proud of that, and really the number of brilliant young people, you've met one of them here today, is just astounding to me. Is there an increased risk of blood clots? I don't know of a study that shows that. Dr. Nance, do you know of any that show that?
I think it'd be related to immobility.
Yeah, so there's, anytime you're immobile, that risk goes up, but we don't know specifically in Parkinson's disease. The risk that goes up in Parkinson's disease with advancing stage is the risk of fracture and osteoporosis. And the other thing about the DBS programming, this is all a collaboration, I think. As new forms of programming are developed, it's collaboration with the device makers, so they have to put the programming in the device. And they're very good about getting out in the community and teaching people new programming paradigms. They do that with us whenever they put something in. So I think that is definitely going to be part of it. Are we as a university going to have seminars or something teaching programmers? I think if we develop new things like coordinated reset, we would do that.
Thanks. We have a question right here.
Thank you. First, as an aside, many of you have seen off periods. You just witnessed an on period from me. I got carried away. Happens all the time. I wanted to ask about palliative care. My background is my father started the first hospice in Texas 50 years ago. We lived with palliative care and hospice care. But your slide didn't mention any of the traditional things that I think of as hospice care: pain relief, nausea relief, itching, all those things that sick patients get, management of skin.
Right.
Okay. So did I miss something there? Or
I think I deliberately did that because I think that's a small part of palliative care for the Parkinson's patients. I think when very advanced, those things come in. I do think that advanced care planning is the rubric now that people talk about. Well, if this happens, what do you want? What are you looking for in the future? I think that can be done at an earlier stage, like all of you obviously are. So the big point I wanted to make is when you hear about palliative care, they aren't talking specifically about what you're talking about, which is hospice care or end-of-life care.
I didn't state that well, once again. I think I've been volunteering with the Pedal and Roll and other exercise programs. I strongly agree with what you say about exercise. It has to be aerobic. It has to be at least 30 minutes, and that's anecdotal. And there are plenty of groups in town to do it, the boxing, the cycling. So I'd like to encourage more people to think early on as all those other things that make life better. It doesn't matter if it doesn't cure the Parkinson's. If they feel better, if they do more, if they get along with the family, it worked. So I'd like to broaden the definition of palliative care. Just make the patient feel better. Any way you can do it.
Absolutely, and I think we all strongly encourage patients, no matter what the stage, to engage in aerobic activity. I mean, in an early stage, you might do boxing or something that requires a lot of agility. I can't do it. If you saw me over here, I'm a neurology nerd. I couldn't do these exercises. But yeah, whatever you can do. But in later stages, we tell people just do something that makes you move for 30 minutes. You can get an exercise bike and just pedal slowly. Do what's realistic, but do it for a duration of time so we can get that growth hormone released into your brain. Agree with you completely.
Another question right here.
Hi, I was wondering if you could tell us anything more about either the systems or devices or pills, medications that are about probably to be approved by the FDA?
Yeah.
I mean, what's really on the cusp?
The sublingual apomorphine is on the cusp. They went to the FDA. The FDA said we need a little more information. They sent it back to the drug manufacturers. All of those synuclein therapies are not on the cusp, but they're moving forward at a fast rate. And I think what one of the people said, who Dr. Nance told me knows a lot about research, said, talk to the FDA and make sure they fast-track medicines for Parkinson's disease. They claim they are now, and for the most part they are. But the more they hear that patient advocates want these things fast-tracked, the faster they'll go through the FDA. But when are those medicines, the synuclein medicines, going to come? You would think that phase 2's a year, phase 3's 2 or 3 years, and then they're going to come to the FDA. What else is on the cusp? The drug pumps are phase 3. They'll be, if they're acceptable, they will be out probably within a year or two, I would guess. The inhaled levodopa is available now.
Question up here.
Okay, so in essence, to that last statement that you made about the inhalant being available, if you have a Parkinson's patient who's already in the complicated phase of Parkinson's, is something like that going to actually be of much benefit to them if they haven't been able to take the carbidopa-levodopa prior because of digestive issues with it?
Yeah, no, if you aren't tolerating carbidopa-levodopa pills, inhaling it isn't going to be any different. It's not going to be any advantage. So it's for people who have good response, tolerable response to carbidopa-levodopa, but they get into these severe down periods and they need to get out of them quickly.
Okay, so it won't bypass the problems with somebody taking the pills and having digestive issues, or?
Well, that's a good question.
Because that's what my dad has and hasn't
Yeah.
been able to take it.
That's a good question. I don't think I know the data on it. The people who make it are right back there in the corner, I think, and it would be a good question for them.
Okay, thanks.
Yeah.
Two questions about the small molecule
Yeah.
theory. One is, does the fact that it has shown promise for these other diseases, how much weight does this carry for Parkinson's? And secondly, the fact that it has shown promise or success with these other diseases, does that help with the FDA?
That's a good question. Definitely, to me, the fact that they help these other diseases I saw in my residency, and I said, these are awful. They'll never be cured or helped. That makes a big difference in my mind. And this new study, just in the New England Journal of Medicine, that it was tolerated in Huntington's disease, and this mutant protein, which is called Huntington, the value of it dropped in the spinal fluid, shows that it's tolerated and the concept works. There's a company now that has a small molecule for Parkinson's, and I think we just have to see, but you hate to be like the person on the Meghan Markle headline, but I think it's going to work, honestly. I think it shows, at least conceptually, I think it has the most promise, and as I say, if it gets through phase 3, I'm pretty sure the FDA would fast track it.
We have time for 2 more.
I just demonstrated a brain fart. I lost my short-term memory.
I do that all the time. Okay.
Oh, one more. One more question down center.
Lately, employers have been having a difficult time finding employees. How does your pipeline look for students coming into your field? Do you have a good...
Oh, yeah, there's a great excitement. We get a lot of students who are interested in Parkinson's disease research, mainly because of Dr. Vitek's huge research team. There's really, when you go to his meetings, it's amazed how many students are interested. So I don't think there's going to be a shortage of people interested in researching Parkinson's disease.
Going once, going twice. Oh, one more.
Could you briefly address the question of the role of inhaled levodopa in patients who have sensitive to high protein in their diet?
Have what?
Protein in the diet.
Oh, yeah, yeah. Well, there's 2 parts to protein, and that's why I think it'd be worthwhile talking to the people. The medicine's called Inbrija. One part is getting it through your small bowel, so protein competes there. But protein also competes when the L-DOPA is trying to get into the brain. So I'm not sure, I just don't know whether that problem, and there are people who say, my life is miserable because I can't eat protein during the day. If I do, my medicine just doesn't come on. I don't know if that problem was shown to be bypassed by inhaled levodopa, but talk to the people who make it over there.
All right, let's thank Dr. Joseph Matsumoto for
Thank
sharing
you.
his time with us.